Thank you very much, Darius. So I'll try, it's a challenging task, of course. This is not a training course, but I'll try to make an overview of the subject, of the practical approaches to manage doses exposure to patient and medical staff performing interventional procedures. Again, starting from where I finished yesterday, that we should never forget that treatment goal is the most important. So this is what medical interventionalists should and always have as the primary goal. But at the same time, there are risks, and these risks should be properly managed, and they should be a part of the routine work, routine patient care. And radiation risk is one of these risks for patients and for medical staff. So there are measures that can be applied before, during, and after the interventional procedure to reduce risks to patient and to medical staff. I'm not separating them because they are very much linked to each other. So just a summary of what I discussed yesterday, and everyone here knows there are two types of risk, stochastic and deterministic tissue reactions. For tissue reactions, there is a threshold dose. For stochastic risk, there is no threshold, so we aim to reduce all risks as much as possible, of course, having the primary objective, the benefit. But in addition to the radiation risk, there are a number of other risks in a clinical environment that interventionalists should deal with. And for example, this for medical staff include the use of toxic agents, infections. A lot of publications are on the orthopedic complications, neck and back pain, spine damage, and many other complaints, mostly because of the use of protective garments, long periods of standing, and maintaining awkward positions. That's why the ergonomical aspects of the protective devices are extremely important. For the patients, there are also many other risks, so radiation is one of those, and it's important to deal this in a proper way. When we speak about radiation risk management, it should be a part of the global quality assurance program in any department, including the interventional department. So, and there are always two aspects: equipment we are using and people behind this equipment, because the best equipment, the most modern equipment, would make much damage to the patient and to the people who are using it if improperly used, without proper knowledge. So they are, from the equipment perspective, the design features, configuration, quality control, maintenance are important aspects of quality assurance program and risk management. On the other side, the competence, and this is not just knowledge, but these are also behaviors, the culture. We are speaking more and more about safety culture, how we are using all the devices we have in our hands, responsibility, the responsibility of and accountability of everyone. So I'll start from the equipment, because the modern equipment that interventionists have in their hands nowadays have really many dose-saving functions. And the first, when we start working in such an environment, it's to study very well the equipment features. We have conventional fluoroscopy systems, C-arm system, single plane, biplane system. Which one is to be used for depends on the purpose, on the intended clinical uses. For example, biplane systems are not for every interventional procedure. They are used mostly in neuroradiology or in pediatric cardiology. So there are specific requirements for the use of each of these, and also the specific functions, features of this equipment. Here on this slide, I try to present the main components of a modern fluoroscopy system. This, in fact, is a angiography system, a fixed system, for which normally high power generators are used, high head capacity. Normally 2 or 3 focal spots, that's very important for proper resolution of the images, depending on the purpose. High filtration, extremely important dose-saving function. Image receptors that also can be and should be selected depending on the clinical task for which the angiography or the C-arm will be used. And for the modern fluoroscopy system, automatic dose rate control is also very, very important as a function. Pulsed fluoroscopy is used in all modern fluoroscopy systems. In fact, continuous fluoroscopy should not be used. Pulsed fluoroscopy is also with several selectable modes from 3 pulse per second to 30 pulse per second. 30 is in fact equal in dose rate to continuous fluoroscopy, so 30 should be used very rarely. Also you can see that from 30 to 3 pulse per second in this case, because it also depends on the specific equipment, there is 4-fold difference in the dose rate. There is also variable pulse width, because in some cases when we aim to have better temporal resolution in a rapidly moving organs and tissues, like in the heart, the small pulse width is very important. So pulse rate selection depends on the imaging task. Higher is normally used for rapidly moving organs. For example, 30 is maybe only justified for cardiac procedures in children, but even for that, there are many publications showing that 15 pulses per second is enough. And for majority of others, even less is enough. So I was very happy to listen from the previous speaker about the use of 2 different modes, fluoroscopy and DSA, or in fact, this is acquisition dose radiography. And every interventionalist should know that the use of acquisition, it's just tapping on the other pedal of the control pedals of the fluoroscopy system, increases the dose rate at least 10 times. So 10 to 40 times higher dose rate, because acquisition mode uses much higher tube current, MA, 400, contrary to the low MA used in fluoroscopy, because of the need to increase the signal-to-noise ratio. So this, of course, is needed, but it should be used very, very when it's really justified to be used and when needed. And nowadays, modern fluoroscopy equipment has many dose-saving features that can be used for, especially for archiving purposes. For example, the saving of the last image hold, the last series hold, and also the function store and replay, that at least the last 300 frames could be saved. So instead of saving or archiving with acquisition mode, this is sometimes absolutely sufficient. But the most important is that interventionalists are aware of the big difference in the dose rate that exposes patients and also staff with much higher dose. Another feature is the beam spectrum shaping filters. I mentioned copper filtrations, but there are also other filtrations used to shape the filter, depending especially if a contrast material is used, to shape the spectrum to fit the best the absorption age of the iodine, and also the wedge filters that are very important, especially in cardiology, to improve image quality, to maintain image brightness in image quality, but they also, of course, help reduce dose. Another function, of course, collimation. Collimation increase the contrast, improve image quality, reduce dose to patient, reduce scatter dose, reduce dose to the staff. And the modern system has so-called virtual collimator that you can position the beam without, in fact, X-ray exposure. So this is you are using the last image hold and without extra radiation positioning the beam. So these are two functions of the modern system, virtual collimator and also automatic positioning, that help reduce dose. Another feature is, of course, the removable anti-scatter grid, because anti-scatter grid is not needed, for example, for children and small objects, and in many places it's never removed, just used. There is a requirement for the vendors that anti-scatter grid should be easily removable from the angiography systems. Automatic dose rate control in the modern system works in a very complicated way. So in the past, this controlled only the tube current and tube voltage, but nowadays their system that automatically control also the filtration is also the focal spot and pulse width. So in fact, the acceptance testing of the fluoroscopy system and the regular quality control of the system settings has an extremely important role to measure, to find how this automatic exposure control system works. And for the operators, it's very important to know the control panel, because they are operators, selectable fluoroscopy modes, that uses different logics, and the operator, either interventionalist or technologist, should know which of these mode is linked to what kind of exposure, and of course image quality, because these functionalities are there to be used for the best result of the procedure. Another way to reduce dose is to use less electronic magnification, so-called zoom or MAC, because we have to know, of course, sometimes there is a need to use magnification, but we need to know that using magnification is linked to increasing the dose. Dose between 1.4 to 5.5, if this case. Of course, this is for image intensifier, for the flat panel detectors that are in the modern system. The logic is slightly different, but still there is, as you can see, increasing the field of view, the dose rate is decreasing. So the actual relationship of the image incident air camera rate and the field of view depends on the vendor and should be checked at the commissioning of the system. So there are other features. Three of them are, I think, the clinical professionals who presented in the yesterday's session and today were referring to this many times: DSA, rod mapping, COMBIM CT, rotational angiography. So these features, of course, have many clinical applications and importance, but they should be very well studied from the perspective of dose. Image processing algorithms are also in the hands. There are new features of the equipment that help improve image quality and sometimes saving dose. In modern interventional departments, large screens are used. One may say that screen, what is the influence of the screen on the patient and staff dose? There is influence, because using these large screens, there is less need of use of magnification mode. Using less magnification, as I have shown, is linked to decreasing dose to the patient and dose to the staff. So, and also, when a small monitor is used, as you can see on the left-hand side picture, the interventionalist is moving the eyes closer to the monitor and very close to the beam. So that's also another increase of the dose rate to the eye lens, especially. So system configuration is something that the staff cannot control. This depends on how this is manufactured and how this is set by the vendor, but it's very important this to be checked at the commissioning and the acceptance of the new imaging equipment, to know the equipment and the features. And there also another set of parameters that could be adjusted to the local practice and user preference. And in this case, application specialist or a local super user can have access to modifying these parameters in collaboration with the hospital, medical physicist, and experienced representative of the clinical staff. So hospital medical physicists have important role. They are present during the acceptance. They are responsible for the commissioning, and they are, in fact, the specialists who know the best, in the best way, the equipment and can help optimize the practice. So then protocol configuration and optimization has important role. It includes proper adjustment of setting customized to the required image quality and dose saving that needs for the clinical task. And this example is from Siemens interface, from one of the very famous papers published in medical physics on optimization, from presets for a nephrostomy exam with different modes used here, in which you see it for the angio, for example, for the fluoroscopy. The default pulse rate is 7.5 pulse per second, and only if needed, the staff have to increase the pulse rate. So starting from the low dose mode is always a good practice. And then also for the acquisition, for the cine mode, for radiography mode, also it as low as possible for the clinical task. So this protocol configuration and optimization requires clear understanding of the system features, functions, program architecture, as well as the clinical requirements and operators' preferences. Here we have the role of the engineers, the service engineers, the role of the application specialist, the local interventionalist, and also clinical medical physicist and technologists if they are available in interventional settings. So required image quality and objective is needed to be and to set the proper acquisition programs. Equipment commissioning has important role to characterize the whole system in terms of dose rate, in terms of image quality, because the modern equipment has very stable generators. In fact, measuring KVs, measuring HVL, what's in the past very important, is not of big importance nowadays. Nowadays, it's very important to make a full characterization of the system with proper measurements for all fluoroscopy and acquisition modes with different thicknesses of the PMA phantom, as we can see on the picture, measuring also the entrance surface dose air kerma rate for the patient, and of course characterizing the scatter radiation around in different modes. Then testing and adjustment of the automatic dose rate control setting is very important. You can see here just one example from one system, how dose rate at the entrance of the patient, this is incident air kerma rate, varies from low dose fluoroscopy mode with the lowest dose rate, for the highest, for the normal field of view of 23 centimeters, up to, you can see here, I don't know, I thought that there is a number, but more than 8 times difference in the dose rate for the fluoro plus, for the high dose fluoroscopy rate, and for the highest magnification of 13 centimeter field of view. So these need to be known. This example is from my own practice in Bulgaria when we commissioned a new system. And you can see very similar from fluoro minus to fluoro plus for different fluoroscopy modes from 7.5 pulse per second to 30 pulse per second. So we have to know this before we start using the procedure, the new equipment. So of course, you have to know your local regulation, because for the entrance surface air camera at the patient entrance, there are regulatory limits in some countries, for example, and they might differ. For example, in Europe, the European Commission, it's quite old document, but Radiation Protection Series 162 proposed suspension level of 100 milligray per minute for normal fluoroscopy mode, and also different numbers for radiography modes, for cardiac mode, for example, 0.2 milligray per frame. Quality control program. This is the key for guaranteeing that the equipment works properly. And this is the role of the clinical medical physicist. This is a table taken from the new publication of ICRP, Task Group 108, that will be published maybe during this year. I was involved in specifically the fluoroscopy chapter, and this is the list of the elements of the quality control program. As you can see, the most important parameters are here: image quality, automatic dose rate control settings and performance, and different modes you have, for example, combi mode, dose parameters and geometry and image quality. So making these measurements, performing these measurements at the commissioning and during the life of the equipment at the proper intervals depending on the parameters is very important. And the most difficult is probably quality control for geography systems, because you need either presence and participation of maintenance engineers, because otherwise everything works in automatic mode. But there is good news that the International Electrotechnical Commission adopted a new requirements for a QC mode of the new angiography systems that is expected to be available for the medical physicist performing QC regularly. So for QC program in this field, there are many guidance documents. IAEA is also finalizing a new publication on QC in interventional radiology, but they are also published for QC development with different test objects, task-based model, observer evaluation of system performance, and the QC mode that I mentioned for interventional procedure that will provide opportunities for more comprehensive physical testing, the routine quality control. So yesterday I discussed the dose displays. There are two different dose quantities that have to be also verified. This I did not mention yesterday, but having displays is not enough. These displays should be also verified, and this is the task of the medical physicist during the commissioning and during the periodic tests. So both air kerma area product and reference air kerma displays should be verified, because they are calibrated at the factory, but there are different factors that might influence the changes in these displays. Especially if, for example, an X-ray tube is changed, or something in the main components of the X-ray equipment is changed, this has direct influence on the dose parameters. So we use this for setting and using diagnostic reference levels. I mentioned this yesterday. Dose reference level is a reference to which we compare, we benchmark our local practice. Normally, a national institution is responsible for establishing national DRLs, and then at every hospital, medical physicists together with the clinical staff should be responsible for setting their local DRLs or local typical dose values that should be compared to the DRLs. In interventional radiology, this is very challenging task, because as it was discussed yesterday, the dose is not very well standardized. It very much depends on the individual patient case, so complexity of the procedure may vary for the same procedure, and there are proposals to establish diagnostic reference levels based on the procedure complexity for interventional radiology. So dose monitoring and alert levels are very important. Skin dose mapping was discussed yesterday. Okay, let's imagine we have the best equipment. We have it's very well set, very well maintained, under quality control, but still, how it's used has a significant impact on the patient and staff dose. So some elements of the optimal procedure performance. Before the procedure, especially if it's expected to be a complex procedure, complex case, patient history need to be reviewed for previous images, standard policy, especially for assessing pregnancy, because pregnant patient management requires special approach. If specifically a patient is at higher risk for skin injury, be an obese patient or more sensitive skin, or patient already had recent other procedures in the same area to be exposed. And in this case, there are methods for reducing risk of skin injury that should be applied. And of course, there should be guidelines how we manage pregnant patients, what we do in this case. And of course, if needed, in this case, patient need to sign a written consent form and should be informed and educated. This is a proposal from, in fact, this is from the new ICRP publication, but it's adapted from a publication from the US on an example of the language to be used for informed consent for radiation risk before a complex and potentially high-dose interventional procedure. So during the procedure, there should be clearly predefined responsibilities of all team members. The main operator has always the primary responsibility for the procedure outcome and for the patient and staff safety. Then the control of the equipment could be either by a dedicated staff, for example, a technologist as discussed yesterday, or by operator, by the physician performing the procedure itself. Proper positioning of the protection screens should also be very well known who is responsible for positioning of the screens, and also for monitoring those factors and notifying the operator if alerts are reached. I will show a table with proposed alert levels that can be used to just alert the staff that the dose is achieving some levels and there is a risk of skin injury. So all these functions should be properly and clearly predefined. Of course, patient cooperation, immobilization should be obtained. And before the procedure, so-called timeout. It's important for every procedure, surgical, radiotherapy, but also here, just few minutes of checking if everything is on place before the procedure start. So the training and skills of the staff for all these dose reduction approaches has important role. It has been discussed several times that staff and patient protection are equally important, and we need to know that from the direct beam, the dose rate at the patient entrance is 1,000 units higher than the dose rate at the staff position. even at the operators who is closest to the patient body. This is because the patient is exposed by the primary beam, and only scatter radiation reaches the staff. In the modern fluoroscopy system, the primary beam is always very well limited. This is a part of the quality control as well, to check if the primary beam is limited to the size of the image receptor. It should never exceed the image receptor. So if the staff does not see a part of the body on the image screen, there is no exposure of the staff from the primary beam, even if the staff stands directly in front of the X-ray tube. So there are many studies showing a good correlation between the staff dose and patient dose. It's not always the case. It depends very much on the type of the procedure. For some procedure, there is a very good correlation. For some others, the correlation is not very good. But generally, decreasing patient dose helps decrease staff dose as well. So these graphs are from the islands dose correlated with the DAP, with dose area product in different procedures. So there are simple rules, I mentioned these, which can be used to reduce both staff and patient dose. And for example, the simplest, very well-known principle, time distance shielding, each of these factors can reduce staff dose by a factor of 2 to 20. So without using any, for example, how you are reducing exposure time. It's not just reducing fluoroscopy time, because it's obvious. Fluoroscopy time should be reduced as much as possible. Never, for example, pushing the pedal if we don't watch the monitor. Using pulse fluoroscopy helps reduce time, because pulses are really reducing the time in which the X-ray generator is active. Whenever possible, step out of the room. Of course, it's not possible for the main operators, but it's possible for nurses, for example, who are there to assist and not always probably need to be very close to the patient. Distance is another very important and obvious principle. We know the inverse square law. So stepping just half a meter helps reduce dose sometimes 4 times, because half a meter means maybe doubling the distance from the patient. That is already 4 times less dose. So keep as further as possible. It's very important principle. And this is especially important for assisting staff, because of course the main operator cannot step back much from the patient. Using shieldings, of course, this was discussed in the previous talk, extremely important to have and use all of these: table curtains, lateral shields, ceiling-mounted shields. We very often, when we go to angiography room, see that ceiling suspended shield is available, but it's somewhere on the side. It's not used during the procedure. So it's a habit. I have talked to so many interventionalists from different professionals groups, and their statement is, you need to train yourself. You need just to establish your habits. Because I also hear very often from some of the interventionalists, this is not very practical because it does not, I don't see the patient very well when I'm using the shield. No, this is just a habit. And this is extremely important, that shielding reduces almost 100% of the radiation. Of course, it depends if it's fluoroscopy or acquisition, what is the thickness of the shielding, the lead equivalent. But if it's 0.5 millimeters, for example, more than 90% of the scatter radiation is absorbed by this shield. So typically, silic suspended screens are 0.5 to 1 millimeter. They have to be properly positioned close to the patient body. Otherwise, if there is an air gap between the patient body and the shield, the effectiveness is reduced. And this is a graph showing the effect from real measurements of the silic suspended shields to the eye lens dose. So these shields should be properly positioned and should be always used in the room. Table curtain help reduce dose to the lower part of the body. And you see here without protection and with protection almost zero, because it's very easy to be absorbed. This is scatter radiation. Of course, mobile shields whenever possible, especially for staff, for example, on the left side of the patient, or for anesthesiologist working in the position where there is no silic suspended screen. So shielding is important. There are also some new developments I did not include here. Of course, aprons, better if they are skirt type to distribute the weight because of these ergonomic problems. Lead glasses, as properly mentioned in the previous publication, very important is the shape of the eyelid, of the lead glass, because if the glass does not have side protection and or if does not fit properly the face, the effectiveness is much less. Thyroid protection, of course, should be used always in interventional room. Mind the pedal, which pedal are pushed, fluoroscopy or acquisition, and as less as possible the acquisition, because this is linked to the much higher dose rate, 10 to 60 higher dose rate in the acquisition mode. And of course, if especially the staff is closer to the patient body, I know departments, it depends, of course, on the procedure. When during the DSA, during the acquisition mode, most of the staff goes to the control room. So only if needed, they stay next to the patient. The tube site is extremely important. This is, of course, in angiography room, you can't put the tube above the table, but I have seen this in surgical rooms. For example, when surgeons or orthopedic surgeons are using X-ray tube above the patient body. Of course, in this case, much more scatter comes to the head, to the eyes, because in the opposite side, when the tube is under the table, the most of the scatter is absorbed in the patient body before reaching the open parts of the staff body. It's also help reduce dose to the hands, especially in procedures. It's again applicable to surgical procedures, in which very often hands are in the beam. They should be in the beam. If the tube is under the table, the patient body absorbs almost everything. So the dose to the hands of the operator are 1,000 times less when the tube is under the patient table, under the body. So, of course, the hands should be kept outside the primary beam unless totally unavoidable, and this is a good practice. And another comment here is when the hands are in the beam, this also increases the dose rate because the automatic dose rate control senses the thicker part of the thicker object and increases the KV and MA. Whenever clinically possible, oblique projection should be avoided. Of course, they cannot be avoided always, especially procedures. There are procedures that need oblique projections. And also, at which site, which kind of oblique projection to be used has very high impact on the scatter dose, especially. For example, if the operator stands on the side where the X-ray tube is, the right picture here, the dose can be a factor of 5 higher to the staff, to the operator, compared to the opposite projection. Very often, I have heard this from interventionalists that they avoid having the X-ray tube in front of us. That means they think that on the left picture, the dose is more higher than on the right. No, the dose is much higher because when the tube is closer to the operator's body, the scatter radiation from the patient goes directly back to the operator without any absorption, because in the opposite side, again, the patient body is absorbing and there is distance, air gap that helps reduce the scatter dose. Also, and this is exactly, if horizontal positioning is needed in some procedure, this is needed, the proper positioning of the stab is on the image receptor side, not on the X-ray tube side. In this case, the dose that reaches the operator is just a small percentage of the radiation falling on the patient body and the scatter. Of course, obese patients, and whenever such a patient will be examined or will be on the table, the operator needs to be aware to expect much higher dose, because the automatic dose rate control will increase the dose to ensure that image quality is sufficient. And in this case, this cannot be avoided. It just needs to be known. Of course, these patients are subject of higher risk for skin injuries, and that's very important. Of course, we cannot change the patient thickness, but we can control the presence in the beam of the unnecessary body parts. For example, this boy had this skin injury only because the staff did not notice that hand was in the beam without a need to be in the beam. Just during the procedure, the patient hand fall into the beam, and this increases the thickness of the body to be transmitted by the X-ray tube, and of course the automatic dose rate control increases the dose, and also the hand was very close to the X-ray tube site. And for the same reason, excessive tube angulation should be avoided as clinically possible, because this increases body thickness and increases the entrance dose to keep the image quality. And of course, scatter radiation is increased. That means, in this case, staff dose is also higher. This is a way to reduce risk for skin injury in a complex procedure. Just modifying a little bit the tube angulation to avoid exposing the same skin area, of course, when practical. Instead of pushing the pedal all the time and exposing the same area, distributing the same dose in a long procedure to a larger skin area will preserve the same skin area to reduce dose, because we should not forget that tissue reaction is has a threshold, and if we succeed to keep the dose under 2-3 grays during the whole procedure, then there is no risk of skin injury. The distance from the tube, the previous speaker mentioned that taller operators are exposed more. Of course, this is because the height of the operator has influence on the positioning of the X-ray tube. So X-ray tube should be as further from the patient body as possible, and the image intensifier or flat panel should be as close to the patient body as possible to reduce, this is the second I just said, image receptor close to the patient body. This is the good practice. Use of collimation, I mentioned this as a feature, but this feature should be used. Less use of magnification, because the decrease of field of view by a factor of 2 increases dose rate by a factor of 3 to 4, depending on the receptor type and vendor. It should be known from the commissioning of the equipment. and whenever possible, use the default, the low-dose fluoroscopy and radiography modes to keep the patient entrance dose rate lowest, and having lowest patient dose rate will help have the lowest scatter dose rate that reaches the operator. So this is one of the simplest way of reducing both patient and staff dose, using low pulse rate for fluoroscopy, of course, depending on the procedure, the lowest possible for the procedure type, and using the lowest acquisition mode. Dosimeters, I mentioned this in my comment to the previous talk. 2 dosimeters is the best recommended way, but of course it depends on the national legislation and availability. Normally, the ring dosimeter for the fingers is just optional. It's normally used for a certain short period of time with more educational purpose, and very educational, and I'm happy that this is included in the project to be obtained, this kind of real-time personal dosimetry system with a real-time control in the control room, in the procedure room, when the staff can observe their own doses during the procedure. Of course, it does not mean you have to stop the procedure, but you can modify the procedure if possible. You know, the occupational dose limit for staff, there are no dose limit for patient. And in fact, if adhered to prescribed dose limit of 20 millisievert per year for whole working life, the chance of excess cancer is really very low. And this is acceptable risk that is comparable with other professional risk. This is how dose limit is selected, to ensure that the professional occupational risk for radiation workers is comparable to other professional risk in other professions. So if you practice as low as reasonably achievable, doses and risk are safely below the dose limit, you should always wear your individual dosimeters to monitor occupational exposure. Dosimeters do not protect staff, but they are the only way to monitor and ensure that everything is under control. Monitoring patient dose is also very important. This was discussed yesterday. These are proposed alert levels. This is during the procedure. During the procedure, it's not recommended to have signals, I mean sounds in the room, because it might be not practical, but someone from the staff having the responsibility to observe those monitors and notify the operator that the first notification level you can see here, if only cumulative incident air kerma is available, if it reaches 3 grays, first notification to be given to the operator. And in every next one, subsequent 1 gray incremental, the next notification. So this is very practical to help reduce the risk of skin injury. And after the procedure, of course, produce those reports, archive this in the departmental, and if one of the triggers proposed, these are the triggers proposed by the IAEA, and the same table will go into the ICRP publication. This should trigger follow-up of patients. The patient, what this means, patients should be informed to observe the skin. This is an example of post-procedure patient discharge instruction for high-dose procedure. And if the patient does not call back, the patient should be called to 30 days post-procedure. That means someone from the department should call the patient and ask if there were some skin redness or rash or some changes in the skin. I think Ioana will show us the procedures that they established in their department. So just to finish, extremely important is to have these updates of the knowledge and radiation protection skills. Time by time, you probably know the 10 POLS posters. They are available in Polish as well in this IAEA website for protecting patient and staff. In fact, this is a summary of what I just presented briefly. And also there is plenty of training material provided by the IAEA for the cardiology, for doctors using fluoroscopy outside radiology. The package on diagnostic and interventional radiology is currently under revision. There will be a completely new training package this year. It's ready, but it's under final review. I strongly recommend you to make the best use of e-learnings, especially the first one, the practical tutorials. These are 13 short videos with just few minutes videos to learn effects of various factors on patient and staff dose. So you can see recorded real measurements, real-time measurements with phantoms, of course, in a real interventional room. So, and from this website of the IAEA, you can find many other materials, especially for interventional. Thank you very much for the attention.
Thank you, Jenia, for very comprehensive information on setting the scene of interventional radiology department, and yeah.